So, ladies and gentlemen, it's my very pleasure to introduce our distinguished speaker of today's lecture, Professor Amir Heiman. Amir Heiman is Professor of Marketing at the Department of Environmental Economics and Management at the Hebrew University of Jerusalem. His research integrates marketing models with risk reduction mechanism, focusing on the interplay of risk, information dissemination, and marketing strategies in shaping consumer behavior, preferences, and adoption of innovation. In fact, three core domains anchor his work. These are first, analyzing the effects of pre-purchased and post-purchase marketing mechanism, including post-purchase guarantees like money-back guarantee policies on consumer demand and retailers' profitability. Investigating the influence of information pertaining to production methods and origin on consumer food choice, for example, and delving into consumer decision-making regarding the trade-offs between pharmaceutical interventions and lifestyle modifications with the aim of mitigating health risk. Today's lecture, in fact, focuses on the third topic, and please join me in welcoming Amir Heiman, who will be presenting insights into the topic, the unintended negative effects of pharmaceutical treatment on the likelihood to adopt healthy lifestyles. Amir, thanks a lot for coming, and the floor is yours.
Thank you very much, Monica, and everybody that came here for inviting me. And I'm happy to deliver this talk. And the negative effect of a pharmaceutical treatment, this is a joint work with people from my department, experimental economics and econometricians, and also with two partners from the medical school and from the hospital. The idea is that we are learning or studying the hypertension. And hypertension is a risk factor for cardiovascular stroke. It's one of the #1 cause of mortality. Cardiovascular is one of the #1 cause of mortality, and hypertension is a direct and independent risk factor. At low level of risk, patients are advised to change their lifestyle, meaning to be more active physically, to lose weight, to stop smoking, stop drinking, a long list. At a high risk level, the physicians usually advise to combine, to take medicines and to improve lifestyle, because there is a super additive production function of medicines and lifestyle. A lot of medical studies show that even a modest reduction in risk factors like inactivity or diet can improve dramatically health or reduce dramatically risk. For example, even losing 5% of your weight can help. People can say, oh, I have to lose 30, 40%, but even 5% is enough. Or the walking minimum is 2.5 hours a week. It's nothing dramatic. So if you make it, you will improve it dramatically, and the findings are very, very conclusive. But one would expect that people that are informed about these results will start to be active, lose weight, do physical activity, more and more and more, and change their diet. But the majority of adults in the industrial work do not follow these recommendations. On average, only 30 or 34 around 30.1 do not meet the threshold level, and United States it's more severe. 50% don't meet the 2.5 hours a week. It's nothing. The proportion of inactive people who were diagnosed with hypertension and other diseases doesn't differ from the regular population who are not at risk. One would expect that after you are being informed that you are at risk, you'll take yourself and say, oops, from now on, I need to do something. But it is not, there's no significant difference. It is estimated that between 40 to 70% of the patients fail to make long-term changes in their lifestyle. Only 50% of the diagnosed patients with hypertension succeeded to keep their lifestyle and health supporting level efforts for more than 4 years. It's desperating, this finding. It is not limited to hypertension. The same holds for diabetics. But the dark side of this is not just the patients, it's also the physicians. Physicians don't believe in patients' ability to make changes. So they skip on the first trials stage. They say, let's go directly to medicines. We will not do the 3 or 6 months trial to see whether or not it helped. The literature today studied why, or what are the variables that can predict the adherence to lifestyle changes. And they concentrated on socio-demographic, economic, cultural, medical condition, and decision biases. For example, economic variables like leisure time, income, are well considered as affecting the decision. Cost barriers, time barriers, having poor medical insurance can all affect an adherence. Another factor that was studied was awareness. It began, I don't know how well you are familiar with the studies of Viscasi about smoking, but in the 70s, they thought that people still smoke because they are not aware of the risk and the consequences of risk. So they made a lot of studies and they discovered that people are aware but still smoke. So awareness was not a problem. The same is here. Explaining physical inactivity, there are a lot of factors that the medical literature studies, like depression, anxiety, physical inability, other mental conditions. There are gender differences, environmental, occupation. The people who tend to do a lot of TV watching after work. These were all related to inactivity. But the research problem is that physical activity and the factors that affect the decision whether or not to adhere was studied alone. The same is diet. The same is adhering with the medical prescriptions. There is no research that we are aware that modeled or estimated the 3 factors, the 3 decisions together. And since there are substitution and complementary relationship, there is a need to study the 3 of them together. It is rational to delay your action or adherence if you expect that something will happen. For example, there is a study by a paper by Posner and Philipson saying it is rational not to make a diet because you can expect that if a lot of people will be overweighted, then there will be a high demand to develop a medicine that will take care of being overweight. This is risky, but people can make rational decisions to delay some of their efforts. This study focuses on 3 decisions. There are more, but 3 were enough. The intake of medication, intensity of physical activity, and adhering to a specific diet. It is called the DASH diet. It is a diet that was designed to lower hypertension. It became popular last year in Hollywood because Hollywood stars discovered that it is a very promising way to lose weight. But it was designed not to lose weight. It was designed to reduce hypertension. The model, I will not go into the modeling in details because it's not something dramatic, but we use a state-dependent framework. It means that the benefit and it dependent in the state of nature, and the state of nature is and there is a probability of a state at nature. So they developed it for winning and losing in the stock market. And then it was used into health and risk, which is exactly what we need. Consumer maximize their benefit, but taking the choice of making physical activity, consumption of healthy, proportion of healthy, and doing a sport. And there are some assumptions taken from the literature. One assumption that is a strong assumption, but we are not the first to assume it, is that the benefit when you are healthy is much larger than you are unhealthy for everything. The other assumption that taking medicines reduces risks, that's for sure. But it also reduces benefit. There is some psychological factors, and also it reduces it's costly, and it has some side effects, and you feel unhealthy. So otherwise everybody would take medicines. And the diet is also quite easy to assume assumption. Usually people perceive that dietetic or with food that is healthier is less tasty. This is a adverse or negative link, meaning the healthier is not tastier, and vice versa. And it is not just making tasting and saying, even if you see the package before you take the drink, and you are asked to rank the taste, when the word diet or low calorie or without sugar appears, the ranks are always lower. The last assumption we had to make is why people do not do enough sport. Because sport is costly, but this is not too much, because you can always walk with a pair of shoes. It is not very costly. It is time consuming, okay. But if you enjoy it, it is not time consuming. So there are many studies and also theories that not developed about this, like Stigler and Becker, that were developed about being a listener for classical music. You need to develop some skills to do it, and it takes time. And until you develop the habits, you suffer. So people usually do not get into the point of time where they develop the habits. And one of the, it is not related, it is related, but it is not part of our study, is that the memberships in gyms, usually the average is after 3 months, most of the new members quit. If they would stay for 1 year, then you will get habits for 8 months or something like this. So these are the assumptions. Once we have these assumptions, the results are very, very easy to understand. They're very intuitive. The intuition is that every one of the three means reduces risk in different manner. For example, physical activity is more efficient than diet in most of the diseases. Medicine is always more efficient than everything. If you get the right medicine, the right dose, and you take it in the right time, then it is most effective. So when an individual look on the three decisions and her or his decision is to reduce the risk, he needs to optimize, or she needs to optimize this risk. But the problem is that, and it is very simple optimization, although the platform is complicated. It's like a production function. It's a marginal production over the cost should be equal. But from time to time, there is no internal solution. In this case, it is the corner solution in many of the cases, meaning that, for example, the medicine is so effective, so it reduces the risk. Once the risk is very low, it's not rational to do anything because the cost is much higher than the benefits. And this is the idea, meaning that taking medicine has a side effect of reducing physical activity and efforts of diet. It means that people with low risk will not start with medicines, but people with high risk will start with taking medicines and all the other pharma solutions, and they will not, in general, they will not combine it with other means to reduce risk. So risk is initial risk is very important, and this is a first two hypotheses. But then there is still a question that we need to address. Is it? Maybe people are not wrong. Maybe it's enough to take medicines. It will take care. So the third hypothesis is that the mortality rate would be affected by combining, because this is a finding of the physicians, and taking only medicines or doing only physical activity will increase the risk. Vulnerability is risk. This is other findings that we see. Wanted to show that we didn't invent much. The cost of medicines are covered by medical insurance. So the better the cost, or the better the insurance you have, the higher is the probability that you will adhere with medical treatment. And of course, people that have limitations, mental or physical, will not be able to combine. And it depends also in other factors like the strategy of being active and proactive. Now we go to the empirical. We were fortunate to have access to this data. It's a rare piece of data. It was collected in two cohorts, and I'm talking about the first one. The second one, maybe I will talk in the conclusion. It was collected epidemiological data from 2002 until 2007, and the survey was conducted by the cardiovascular epidemiology unit in the Goethe Institute, that is part of the biggest hospital, not biggest, but one of the biggest hospital in Israel. It has been conducted in an area called Hadera. It's the middle of Israel. The reason it was that there is a high proportions of Arabs there, and they wanted to compare Jews to Arabs. The participants were randomly selected from the general urban, and the sample is representative. The data itself, the advantage is we have actual records, meaning blood test, medication, diets were measured. It's not a survey. We have activity. There are also personal interviews. How much do you eat? What is your food preferences? Why did you stop? And we have all this data and other records. The limitation of the first cohort, it's a cross-section of it. Some descriptive statistics about the data. We compare the entire sample into the individuals with hypertension. So we see that overweight is higher in the diagnosed is 40%. Obese is much higher, almost double. Physical disability is also almost double. And for some limitations, depressed and a self-belief, we call it self-efficacy, meaning you believe in yourself, that being able to make the change, it is lower, and low ability to manage stretch, and total score of anxiety a little bit higher. If you take the percentage of people who don't meet or meet the threshold, which is 2.5 hours weekly of physical activity, you see that 38% do not meet it. But the shocking, not the shocking, but surprising is that more than 50% are not active, meaning they don't do any physical activity. Of course, you go to the kitchen, you do some physical activity, but it is not going out and walking or running or doing something like this. The patients, the number of patients who had with this diet, 7%. It's very difficult to do that. You skip salt, you skip sugar. It's quite dramatic, but you don't need to do all the 19 measures. Meaning you did 4.5 measures. It's enough. Most of them didn't meet it. Distribution of number of medications. So we see that most of the population either didn't take, I will explain it after in a minute, or then took 1 or 2 medicines. There is a need to explain. The decision whether or not to adhere with or to take medicines is dual, meaning physician decides whether or not to prescribe after evaluating the risk and the personality, and then the patient decide whether or not to adhere. This is complex, meaning the 57 is a combination of individuals that the physician decided that are healthy enough to take care by changing their lifestyle, or individuals that were instructed to take medicine but decided they don't want to. Once you decided to take medicines, the decision of how many medicines, it's not your decision. It's the decision of the physician in order to balance. Some people are very, with high blood pressure, that it's very difficult to balance. We have three equations that we measure, we estimate. The endogenous variable in the first one is whether or not to adhere to the pharmaceutical treatment. And the other two variables is physical activity and the diet. And we have social demographic, health variables, mental health, and awareness, and some instrumental variables like physical disability, preference for salty food. For example, salty food will affect the diet, but will not affect the decision whether or not to take medicines. And eating kosher and having supplementary insurance, and the physical activities and endogenous variables of the medicine adherence to the medical treatment, the DAS score, and again, the same variables as socio, health, mental, and instrumental variables are anxiety, family history, and again, preference for salty food. And the same story held with the diet. Here with instrumental is a physical disability, stress level, and family history. Now the results. The results are the first equation that we estimated is using IV probit, and most are interesting, but the dramatic one from our side is the negative sign that is significant of physical disability, physical activity, meaning that individuals who do more physical activity or more active tend not to adhere to the pharma treatment. Then we have also the diet was not significant, and we have marginal effect of schooling and age. Older you are, the higher is the likelihood that you will have the hair, and being overweight or obese, again, increases the likelihood to adhere to the pharmaceutical treatment. And now we estimated the physical activity equation. And here we see that there was a mistake, I see, the first no, there's no mistake. Takes hypertension medication reduces the likelihood of doing physical activity, meaning that we showed that our expectations are true. And there is also a trade-off between the diet and the frequency, physical activity, and again, schooling and age and employment increases the likelihood that you will adhere with physical activity. With a DAS score, it was two variables were not significant, and being a male reduces the likelihood of adhering with this diet, but socioeconomic is not something that we wanted to stress on, but it's nice. So the summary is that specifically we found that anti-hypertension pharmaceutical treatment was associated with decrease of likelihood of physical activity. And reversal is also false, but this is not something that is dangerous. It means that people can say, strategically, I want to treat myself and do physical activity. Let's see if it works. If it works, fine. But the other way around, that saying, okay, I will take medicine and forget about lifestyle, this is dangerous. So now we need to show the second part, the relationship between adhering with a pharmaceutical treatment with a single mean to control the rate of mortality. Yes, thanks. I think this is the second cohort. The second cohort was collected between 1913 and 1917, but there was a ongoing data collection until 2020, meaning the mortality rate is until 3 years ago. And the mortality rate, if you see, we had 230 responders, only 50% survived. Between the 2007 and 2020, they were sick. They were not healthy people. Some of them passed away before the follow-up, some of them passed after the follow-up, and 50% are alive. We had we stratified the second cohort into 3 groups. One group that didn't adhere to the pharmaceutical treatment, which was a small group, then adhered only to the pharmaceutical treatment. It was the largest group, and combined. The difference between the groups we tested, and there is difference. There are not the difference in socio-demographic and age, and the only difference we didn't find is between Jews and Arabs. They behave the same. The group who adhere to or combine are younger, less educated, and who didn't combine. Now, the difference in one question that we need to address is whether the results are caused by the behavior or caused by risk. Maybe people or individuals chose their decision based on their knowledge of the risk, and so we cannot explain it. So luckily, we had data from another source, the health provider. We have something that called the Charleston Index that measures the likelihood to survive. And we compared the 3 groups. But first, we show the mortality rate. We take the first group and the third group, and we want to compare a single to non-single, and we see that there is a difference. All three groups are different. The third group that combines was in the riskier situation. The second was in the middle, and the first didn't adhere to medicine was with a lower risk. This is rational. Now we want to show the mortality rate. We see that the mortality rate in the group that took only medical or pharmaceutical treatment is 58%, while in the groups that combined, it's 41%. Recall the previous slide, it was a group that was at high risk. Yet combining reduced effectively the death. The first group that didn't adhere to the medical, to the pharmaceutical, did it for a reason. They were more healthy, and the mortality rate is lower. So we supported that physical activity efforts combined with medicine reduces the mortality rate, and the policy implication is not just to explain, is to change to do something we call debiasing. And the decision not to combine is a biased decision. So we need to change it to make people aware about the consequences. This is one way. Other way is to subsidize physical activity. The motivation to do this research was from the health insurance, social insurance in Israel that tried to think about a mechanism to take the tax depending on the efforts that the individuals do to keep themselves healthy. They didn't pass it because of political, but they got the data. So the trade-off between medication and nutrition, it's complicated. And a technology must also be developed to assist in order to control it. Now, before I finish, because this is the last slide, of course, we are still in the beginning. We are now analyzing the second cohort, and then we do a cross-section and comparing the individuals that survived or died between the two samples in their behavior. This is one. Oops. This is one direction. The other direction we are working, we collected data from Europe, and we showed the same results. But in Europe, we had very good data about weight loss and not about diet itself. So we showed that losing weight behaves like physical activity. People who adhere with medicine tend to not to lose weight, even to gain weight. And the future is still there to continue with it. It's important for the medical society, but I think also for economists, because the health cost of treating individuals who neglected themselves is enormous. And you can prevent it quite easily by educating how to combine. It's not such a dramatic change. So thank you for being such a nice audience, and
Okay, thank you very much. Please stay with us. Just for organization, so if you are on Zoom, please write your questions into the chat, If you're in the room, of course, you can just raise your hand because we don't have speakers here, so we won't hear you if you're on Zoom. Any immediate questions, Monica?
Thanks a lot, and a very rich and interesting data set you are able to work with. I was just wondering, you mentioned at the beginning some of the problem is really linked to the doctors, because if I understood that correctly, they are too easy in prescribing pharmaceuticals, and that kind of leads to the substitution effect, which in the end leads to an earlier death. Is that correct? So we would need to start with the doctors, not with the patients.
Both, I think we need to address both, but when you present it to the physicians, they always say, we knew it. We knew that we had the easy hand on medicines, but we don't believe in the ability of people to change their behavior. So we need to start with them. We need to educate them. I don't know. Most of the physicians don't know enough about diet. They never learn it in medical school. They know it is important, but not more than that.
Additional questions in the room or on Zoom? You let me know if there's something on Zoom. I had just a clarification question. So I didn't fully grasp the part where you compared the risk, the mortality risk in the three groups. So the group that rather took physical action and not medicine was the one with the lowest risk of mortality? Okay. But that's the risk of mortality is controlled for in the analysis, or does that influence the? Okay. Any other questions? Yes.
Maybe another question, because I mean, you have three activities. You have taking the pharmaceuticals, you have the diet, and you have the physical activity. I did not really get how physical activity and diet really complemented each other. What was the effect? Could you elaborate on that a little bit?
Not in this study. In this study, we didn't find substitution nor complementary, because the DASH diet is not very popular, except in Holland. But in the European data set, that we just finished analyzing, there is a complementary and substitution effect, depends on the group. So the more data we have, or better data we have, we can adjust for the two. I didn't receive the data, but when I presented it in the United States, they said someone from Rutgers, the same in the icon said, I have the data and I know that there is a complementary effect. But this is an important question, because people tend to do diet and not physical activity. But this is for other reasons, like because diet has other benefits, like looking better. Physical activity also does it, but in a very long period of time.
Questions in the chat. The first one was on how you measured effective stress handling.
I don't know. The medical or physician did it. The questionnaire, and if it is very interesting, I will ask the students that collected the data to answer.
Okay, and there's a second one here. I will make this a little larger. So Alma, if you want to know how you handle your stress effectively, our guest speaker can look it up for you. The second question is, thanking for the presentation. And the first question you raised regarding the MDs, you assumed that pharmaceutical treatment is assumed to reduce benefits. So what is the legitimacy of healthcare? Is actually the problem that you addressed more on the physician's side, or why are people not trusting their
about psychological side effects, and once you take a chronic medicines, you feel that you move to another stage in your life. And this is something that is known in the psychological and medical insurance. In Israel, you don't have a problem of cost because there is a social healthcare, so everybody gets medicine for free. So this was not an issue. But the issue is that psychological and cultural variables affect the benefit. Meaning you take it, you feel unhealthy, reduces benefit. It's like I'm for marketing, but once they studied why young people in the United States refuse to drink Diet Cola because of the image. Once you drink Diet Cola, you say to yourself, I am overweight, so I cannot accept it. The same holds, I think, for the medicine. But this is an interesting question to study it empirically.
Other questions? No? There's one. If you want to ask it, come over here then.
Yeah, thank you. Just really a really simple question of understanding. When you look at your models and you look at the probability of somebody accepting this treatment, this pharmaceutical treatment, what is the sample actually? Maybe you said and I missed it. Is it only people that are have some kind of risk regarding health, or cardiovascular health risks, or is it the total sample of also people that are not confronted with that risk?
In details, the sample is people who are diagnosed and were prescribed with the medicine. So they should have taken the medicines. We have larger group, the people that were diagnosed but were not prescribed with medicines, and it changes a bit the results, but not dramatically if we do a sensitivity analysis.
And maybe, so what would be your policy recommendation at this point? I mean, you indicated you are still working on some kind of data for Europe, and that is a bit different, but maybe from what you observed now in Israel, and would you, I understood it was also a little bit different for different segments of the population. Would you then also need to have a more targeted kind of policy depending on whom you are dealing with?
I think one obvious recommendation is to subsidize all the diet and weight management. Today, it doesn't taken care unless you have a very good insurance. So only rich people can benefit from it. And since cost-effective regarding policy, this is one trivial recommendation. The other one is to subsidize physical activity. And in Israel, they started doing it, not because of us, but because of other studies. And they build outside a free access gyms that people can train, and it is nice. There is music. A lot of people are training, so you don't need to actually buy a membership in order to do it. And there are a lot of walking routes built. So you need to make it more accessible and less costly. And then there is the information. The information, I think there is a need to educate the physicians. But in order to educate them, we need first to publish it. Maybe, and because whenever we present it in the medical community, they say, it's so interesting, publish it. It's not easy, but we are working on it for 6-7 years. But now we are close to the end.
So two related questions. Is there actually evidence that subsidizing gyms and things like that actually increases the number of people who use that? And regardless, isn't also physical activity something we should maybe start very early in life, sort of teaching and creating the habit rather than, of course, we have to do something now when people are there where they are right now, but you know, a long-term mitigation strategy would probably be to also start making it, strengthening that in school curriculums, things like that. So if I look in, I mean, I do have kids in school and they have frequently no sports lessons because teachers are sick or they don't have infrastructure to do the sports. So if I look forward, that doesn't look good for the future and cardiovascular diseases and all these things. So where do we start and how effective are these subsidies for physical activity?
The first question of do we have measures of when we make it free of increasing the quantity of or the time of people? We have only anecdotal evidence, but it is a good idea to make a survey. The second one, you are certainly right. I know it on the diet issue, not the physical activity, that it is very difficult to get used to eat vegetables, for example. If as a child you didn't eat vegetables, likelihood that you will eat it as a grown-up is very slim. Like eating especially vegetables that are sour, like a broccoli. If you give it to a young child, they will resist it. If you give it when he's young enough, or she is young enough, they will not resist it, and you build a habit. It's more easy to develop a habit for chocolate than for vegetables. The same holds with physical activity. I don't know the situation in Germany, but I know that in Israel, they reduced dramatically hours of physical activity and increased all the theoretical studies and Bible studies. So Bible is important, but physical activity is also very important.
Okay, so vegetables are like classical music. You have to try them out for a while before you can enjoy them. Any other questions? I don't see anything on the chat. Chat is okay. Then I would say we thank you once again very much for coming. And I learned a lot, I must say. I'm going to try to implement the recommendations at home. And thank you for coming. Enjoy the rest of the Christmas time and see you in the next lecture, hopefully next year.